It's really exciting for me to be here today, helping to facilitate this panel on different testing approaches with my esteemed colleagues, who I have a great deal of respect for. We have one more speaker, Nate Lachowski, who I'm assuming will come at some point. He's probably around. Here he is, great. Nate is going to join us. I'm sure there was keen interest in your presentation, Nate. No worries. So I think I'm just going to set the stage a little bit. And I think, when we were talking about this panel, I mean, obviously the theme of the conference is about improving access to healthcare for GBT2 communities in Canada. And so this is around looking at improving access to testing. And so I think all of us know what the sort of the traditional model of testing is, right? So the traditional or classic model would be going to visit a healthcare provider, a physician or a nurse in some kind of setting, whether it's a GP's office or a clinic, having, some form of counseling and interaction, tests get done, so specimens get collected, sent to a lab for testing. You get results in a week or longer, either in person or sometimes over the phone. So that's sort of a classic model or traditional model of testing, and that's still a very important model of testing. There are definitely times when people need to be speaking with a healthcare provider. There are many sexual health issues that can get addressed in that context, and ideally it would be great if all of us had equal access to like completely culturally safe, sensitive testing, in-person testing that meets our needs. But we know that's not the reality in Canada, as I think Nate put it in the last presentation, that testing access is a geographic issue. And so that's what we're going to be talking about today. So after I finish setting the stage, we'll turn to our panelists. I'm already doing a bad job as facilitator because I have the speakers listed in the wrong order. So we'll start with Devin Haig from the BC Centre for Disease Control, who'll be talking about internet-based testing for STIs. Maya Carlson from Interior Health Authority, who'll be talking about on-demand testing. Hans Bosgood from the Health Initiative for Men, talking about express testing. Then we'll have Nathan talking about dry blood spot testing, elaborating a bit on what he's talked about in the last plenary, and Ryan Lisk from ACT, talking about community-based approaches to anonymous testing. But we want to have lots of time for discussion, and so we'll go through that. So just to set the stage a little bit, this is data from 2018 of the Sex Now survey, and thanks to Nate, and thanks particularly to Aidan for pulling and looking at this data. And this just shows, the red bar shows the number of participants who said that they were tested within the past year. And so we can see that, between 50% to 72% or so of people say they've been tested in the past year. This is a really, crude analysis. There's lots of reasons why people may not be tested in the past year that are legitimate, but clearly there's probably room for improvement that we can be doing. And we do see some differences across the country. I think what's a better metric in terms of testing barriers is asking the question that was asked in terms of whether there was any reason that caused you to delay or skip testing in the past year. And here we can see again some differences. Congratulations to Quebec, because you must be doing something right, because it's a lower proportion people who reported delaying testing in the past year. But still, we can see a fairly significant, from a third to 50% of people say they delayed testing in the past year, which likely reflects some form of barrier in accessing testing. And the most common reasons were being too busy to get tested, the hours were inconvenient, being stressed out, anxious, or depressed, and that the wait time for an appointment was too long, being sort of the most common reasons amongst other reasons that you see listed there. So when I was thinking about how to sort of describe sort of different methods of doing testing, or complementary methods of doing testing, or these different modalities, I came with a very complicated flowchart and decided instead, for me, it sort of centered around these 4 domains. So what test is used, how the test is done, who does the test, and where the test happens. So in terms of what test is done, this is really about the test technology itself. We know that there's different kinds of tests. There's screening tests, and then there's tests that are confirmatory. We know as well that there are test kits or devices that can be done at a point of care or in a clinic, versus those that are done in labs and require the typical collection of specimens and sending to a lab. There are differences in how the testing can be done. So there are tests that can be done fully anonymously, or tests that can be done to the range of tests that are done using your full name. There's variations on the extent to which their pre- and post-test counseling can be incorporated into testing. Who does the test is also differing. I mean, we're moving towards, hopefully, having self-testing soon in Canada. And so that's sort of the extreme of people doing the test themselves or providers doing the testing. Also, we can think about different ways that people collect specimens. So people can collect specimens themselves, even if they're not doing the testing, versus providers collecting the specimens. And then again, there's a variety of places where test happens, right? Ranging from hopefully the home, but even now you can order some test kits and get tested, to various ways throughout community and into the healthcare system. So my take-home message around testing is always that one size doesn't fit all, and similarly, one size doesn't fit all communities. So looking at, this is going back to the 2015 data, but this was data that looked at whether people had an HIV test in the past year, stratified by different types of communities, ranging from urban to remote. And you can see that while there's not a lot of differences, there is a bit of a subtle gradient in terms of people in urban areas having a higher proportion reporting having an HIV test in the past year. Similarly, if you asked how often you got tested for HIV, again, not really profound differences, but you do see that gradient again in terms of the highest proportion of individuals reporting getting tested at least once a year being in urban areas. And so again, that probably speaks to some of these differences amongst different geographic communities of gay, bisexual, and other men who are sex with men. So that's me setting the stage. So just to acknowledge as well, some of our examples we're talking about are based in urban settings, but we wanted to include them because they are examples that potentially could be used elsewhere. And also we really recognized in talking about this before the room that while we're all up here talking about what we know, there's probably a lot of experience in the room of people who've had different experience with different types of testing programs in different types of communities, whether those are geographic or other forms of communities within the population. And so we want to leave time to hear from you in terms of what some of may have worked well or some of your observations about testing in other settings. And with that, I will turn it over to Devin.